So this is the after case. This is a 63-year-old male patient from Sohag. He's married with 3 children. He was diabetic for 15 years on oral hypoglycemics. Hypertensive for 20 years on enalapril. In 2016, he had acute coronary syndrome. He had coronary artery bypass grafting to Lima LAD, saphenous wave graft to OM1. In February 2019, he presented with decreasing exertional dyspnea and chest discomfort. So this was his ECG, the original ECG done when he presented there, and it just shows like diffuse ST wave changes, nothing really remarkable, and maybe a Q even a V1. Chest X-ray also just a prominent aortic knuckle and slight cardiomegaly. And he consulted his physician, who sent him to a multi-slice CT and to check the patency of the grafts. This is the first thing that came to their mind, and sent for cardiac surgery consultation. So this is how his grafts looked like. So he did the multi-slice CT. He had a patent Lima to LAD and a patent saphenous wave graft to OM1. So this bit was okay, but this wasn't okay. What they discovered was a large pseudoaneurysm. As you can see, it was related to the lateral aspect of the left ventricle. The mouth measured about 8 millimeters. It was 90 millimeters below. It was very close to the thing. You can see the opening is very close to the papillary muscle, which made it a bit tricky. And only 90 millimeters related to the mitral valve, just located under the mitral valve and related to the lateral papillary muscles. So this is how the echo looked like. As you can see, it's an external chamber outside the heart with an exit point that goes in and compressing completely the left ventricle, as big as the left ventricle. So that was a problem. The aneurysm itself measured about 40 by 64 millimeters, and the opening on transthoracic echo measured about 8 millimeters. And the ejection fraction was only about 40% by eyeballing, so he was really suffering. So what to do next? Consulted the surgeon. The surgeon was not very keen on opening because he had a Lima, which was patent, and he was not going to risk opening the chest and injuring the Lima. So he said, why don't you go ahead and do it? So we said, okay, we'll do it. We haven't done this before, but we'll try and figure out something to do it. We decided on, the whole team looked together and looked at the anatomy, and we decided to have TE guidance. The route was important, so I'll show you how we discussed the route, how we're going to get in. We had the problem of entangling the chordae of the mitral valve, because if you just going through whether are we going transeptal and then going down the mitral valve, or going through the aorta and then up, this was an issue. And then wires, do we need Teromo wires, stiff wires, and then devices. Of course, we said we could do a double disc device. So we started the procedure by just looking at the femoral arteries, as you see, because we decided to go transaortic. They are very, very tortuous. I usually do this when I'm doing, because I've learned this the hard way, I'm doing any coarc or even it happened to me in a younger coarc. She was 17 years old, and we had complete laceration of the femoral artery. It was a redo. She had a fractured stent, and we went trying to put in another stent. Due to fibrosis, we had complete laceration with the femoral, and she had to go to a vascular surgeon to do a bypass. So I usually do that, just check the femorals and see how they look like. And then we did coronary angio, everything was okay, Lima was patent, saphenous vein graft base, everything was fine regarding the graft. And then we did the 3D echo. As you can see, the opening is here. This is the chamber there. And then you have the chamber there, you have the opening there, and we have to look at this, and we did some measurements. These were the measurements we took. We wanted to see how big it was, so it's about 11 millimeters, 10 millimeters from the papillary muscle. Thickness was about 9 of the septum, and then 12 millimeters from the mitral valve. This is from the 2D echo. These were the measurements we needed to take. We then went through the aorta, and then with a Teromo wire, we tried to initiate this across the mitral valve, across this opening. We didn't do much contrast, because really whatever amount of contrast you're going to get is not going to give you any measure, because the aneurysm was huge. So we depended on TE in certain managements. We could then cross into the Sudan years. I had two problems then. First problem was we needed a stiff wire, and then a stiff wire if we're going to put inside this cavity for danger of perforation or something. So we were worried about the tensor apparatus, so we just had a TE guidance. So what we did is, as we do in the mitral, we had a big coil on the stiff wire, and this is what we did. We just advanced the stiff wire and measured the thickness also there, and then started the procedure. So it was an unfolded aorta. As you can see, we had a big coil here and tried to keep it, in the cavity and looking down, not to have it too much protruding inside. The problem was it was an unfolded aorta. The sheath was too short. It just came in here and stopped. So nothing to do. So we weren't sure what to do. Somebody suggested that I should do an over-the-wire procedure, which is sometimes I do with an ASD, and maybe you can slip it in. So this is how we do it. We just put the device in and then thread it on the wire, and you can see here, you thread the wire in, and then you take the whole thing inside sometimes you do that in ASD. You have the wire standing in the upper left pulmonary vein when you cannot just align it well, and you thread the wire through the device, and you get your device up through the mesh. Yeah, that's what you do. See, through the mesh, and you get it back and put it up. So they said, why don't you do the same thing that you're doing with an ASD? Maybe it's going to work, but it didn't actually. So then again it stopped. So what we thought of, we measured, and we had the Mullin sheath with about 5 centimeters more than the 7 French, and finally we could cross. So we crossed with an off-label use of the Mullin sheath. We had to use sheath in sheath on the back so we don't have much bleeding, and to introduce the device, and we could finally deliver a 20 millimeter Hyperion VSD device, and this is how it looked like on no residual flow there, and this is after just releasing the device. You have no flow inside. Post-deployment echo, yes.
Sorry, how big was the device again?
12 millimeter VSD.
Oh, it's a VSD.
A VSD. I had to have a double disc device. I couldn't take anything else but a VSD device. And this is how it looked like on follow-up. As you can see, there is much improvement of the wall motion abnormalities. ECG even was much better. The STT wave changes have almost normalized. There was total exclusion of the pseudoaneurysm. There was no encroachment on the mitral valve. And this, you can appreciate the movement of the septum here. That's the lateral wall, I'm sorry. Pre-closure, and that's post-closure. So, and the patient much improved. So, that's our.
Do you know what happened to the aneurysm over?
Yeah, it went down to, it was about 64 by 40. It's thrombosed. It's getting smaller, and we're still fighting over time. I think so.
Yeah.
I looked at the literature. There are a few cases reported after I've done that. Lucky after I've done that, because otherwise I could have gone through what they did, and I don't think I would be been successful. There are 2 cases in literature where they even did it through the chest. So they just perforated the chest through the pseudoaneurysm and exteriorized the wire there. I don't want to do that. So I wouldn't want to do that. So they had you had the wire exteriorized outside, and I wouldn't want to do that. So that was our first case. ممكن تفتح تكييف تاني وتودي. Yes. So this is what it looked like. You see the motion now is much better. Device in place, and we're still following up. So.
We had a case a few years ago, a similar pseudoaneurysm from the lateral wall. It actually went up and pressed the pulmonary outflow tract.
Okay.
And the patient presented with battle-megaline right heart failure.
Went to surgery?
He went to surgery.
Yeah. But the surgeons were not very keen. They said with the lima, we don't want to open the chest again. So with the patent lima. Yeah. So that was it. This is another case. This is a 20-year-old female, shortness of breath, effort intolerance, repeated attacks, chest infection, atypical chest pain, exertional sinus of 2 years duration. Clinically, she has bounding pulse, well felt peripherally, saturation at 92% at rest, loud P2, and systolic murmur radiating to axial and upper left sternum border, and an early diastolic murmur. This is how her ECG looked like. You can appreciate the right axis and LVH with some strain. Echo, there was bivertical enlargement, dilated aortic root with aneurysm of the left coronary sinus and grade 2 for aortic regurgitation. She had a query coronary artery, coronary AV fistula with circumflex to coronary sinus, large PDA, markedly dilated main pulmonary artery, moderate TR, and pulmonary hypertension, and estimated RVSP of 95 millimeters mercury. So I went to a CT, and this is how it looked like. Indeed, she had a very large coronary fistula into the coronary sinus here, and a very large duct, which is apparently unrestrictive. So this case has a double problem. So we took her first to hemodynamic study, and we did on an intent to close the fistula with or without closing the PDA, depending on how the RVSP is going to behave, and with a test pollution of the PDA. This was the intent. So her hemodynamics were as follows. So she had a pulmonary artery pressure of 93. After 100% oxygen, for some times it went down to 73. And also saturation went up, so this was a bit encouraging. Without a change or in the systemic pressure, it even rose, the systemic pressure, and this was very encouraging. So we started the procedure. So at first we did an injection in the coronary fistula. It's a large fistula opening into the coronary sinus. Of course, the problem was not to occlude the coronary sinus, to choose a device that won't include the coronary sinus and will not encroach on the coronary itself, because from the fistula there comes the coronary there. So we don't, AVP2 was not an option, because otherwise you're going to close and have the thrombus propagating up. So we chose to do a PDN ADO one. We first crossed the fistula, exteriorized the wire from the other side in order to put the sheath. She's coming up, and then we do an injection through the sheath to have a look at the fistula. And then now there is the device coming up, the duct occluder. We did an injection, and you can see now it's completely occluding with better visualization of the coronary, of course. So we left it at that, and then went to the PDA, which was very large. And we decided to do a VSD device, double disc device, because she had pulmonary hypertension. So at first we did the double disc device. I don't have a mouse. Mمكن في mouse هنا ولا مفيش؟ لا. I have a mouse. عايزين mouse. So this was the VSD. This is the VSD that did not sit well. So we decided finally on a larger ASD double disc device, 12 millimeter. This device, we put it from the pulmonary end, and this was how it looked like at the end. So follow-up echo is tightly closed duct. You can see here by 3D echo, you can see on fast view the device in the pulmonary artery. Still has aortic regurgitation, and coronary sinus not affected. So this was one of our successful cases. But it's not always that easy, because I can show you this other girl who is 4 years old and 7 months, 22 kilograms, diagnosed as having coronary fistula. And 2013 she was first referred, and we did an echo. This is a very large coronary cameral fistula, and we tried crossing it, and we could not. So we left it at that, because at the time the patient was asymptomatic. She came back again in 2014. We could cross and do a loop, but we could not pass the sheath from the other side. So then we abandoned the procedure again. And then this in 2016, this is how she looked like. You can appreciate that the left ventricle started to dilate, aortic regurgitation increasing. She's starting to get more symptomatic, so we decided to go ahead and try and close it. So this is how it looked like. It looked like, one of the we do a lot of these, so it looked like fairly straightforward. We had the loop, We had injection. We looked at all the, you can see all the branches here of the coronary, and we did an injection, and we decided that we want our device. Yes. So this is where we wanted our device. We said we want an ADO 1 of 10 again, and then we thought our device here. So then we crossed the device, put it here, nicely closed, and then nightmare begins. She had an acute inferior STEMI, and immediately, but I don't have the echo, immediately we noticed segmental motion abnormalities. So, and it gradually normalized. I mean, we did that and it gradually normalized. And we weren't sure what to do actually. And we had a debate in the cath lab. They said it normalized, so why not leave it in place? But then she was a 4-year-old child with inferior infarction. I'm not sure about thrombus propagation. I'm not sure about the long term of this baby is. So we decided to just get the whole thing out and abandon the procedure again. So we tried doing that, but we were unable. The problem was, you can see here, there is this angle, you know, the sheath was already out. It was extremely impossible to just get this out because it wouldn't come out. It was just stuck in the coronary fistula and it wouldn't come out. Again, it had a very funny angle. You can see here the sheath became kinked from too much pulling, and then it had a funny angle and it would not come through the sheath. So what next? We had either pull it back or call the surgeons. So we decided to pull. We did pull and pull and pull until we had it back where we wanted, or very near. ECG normalized, looked very funny. We couldn't get it out, so we just left it there. ECG normalized completely, her enzymes normalized the second day. This is how it looked like on the following follow-up echo, which looked very good. But then what we were worried about, that the device was too much entangling into the tricuspid valve here and it's causing mild tricuspid stenosis with a mean pressure gradient of 5, and we're leaving it at that and we're following the patient up. Multi-slice CT later on showed a well-secured fistula and a normal coronary flow, so we were happy about that. So with these two coronary fistulas, I just say there has to be a good delineation of coronary anatomy, planning, equipment, and teamwork with an adult cardiologist on site, just in case something happened, or somebody with a skill in coronary intervention and surgical backup. And thank you.